Hello, and welcome to our presentation on childhood obesity as a form of neglect. Kristin, Katie, and I will be exploring this topic further with you today. The first thing I would like to discuss is the concept of BMI. This is determined by taking into account an individual's age and height, and then calculating their body mass index, or BMI, based on a particular formula. When looking at the American pediatric obesity epidemic, we want to determine what would classify a child to be considered overweight or obese based on their BMI. Children are considered overweight if their BMI is between the 85th and 95th percentile based upon their age and gender. A child would be considered obese if they have a BMI in the 95th percentile, and severely obese if their BMI is in the 99th percentile.
The most recent data on childhood obesity by the CDC was collected from 2017 to 2020, and they found that almost 20% of children ages 2 to 19 are considered obese in the United States. This amounts to 14.7 million children. Among 2 to 5-year-olds, the prevalence was 12.7%. In 6 to 11-year-olds, it was 20.7%, and in 12 to 19-year-olds, it was 22.2%. This rate has been steadily increasing for decades. In 2013 and 2014, the overall prevalence rate was 17.2%, and in 2015 and 2016, it was 18.5%. And there are no signs that this upward trend is stopping anytime soon, unfortunately. Research has shown that significant disparities exist in the prevalence of childhood obesity amongst different racial, ethnic, and socioeconomic groups. According to the CDC, obesity affects children from low-income families much more often than children from high-income families. Families may not have access to or the ability to pay for healthy food, which is oftentimes a lot more costly and difficult to prepare than prepackaged foods. Black and Hispanic children are also disproportionately affected when compared to white children. Many of the families affected by childhood obesity also don't have access to adequate health care. Either they might lack health insurance or transportation to get to appointments and pharmacies. And then if they're not making regular doctor appointments, if they don't have the ability to speak with a doctor about their lifestyle and their concerns, then they're not receiving the health education surrounding healthy eating and exercise. And language barriers may also amplify these difficulties. Finally, the CDC mentions that the prevalence of adult obesity decreased by level of education. Adults without a high school degree had an obesity rate of 37%. Adults with a high school degree had a rate of 35.6%, and college graduates had a rate of 26%. Lower levels of parental education were also significantly associated with childhood obesity. This is a graph of obesity rates in the United States from 1999 to 2016, and as you can see, there's a definitive upward trend. And although this graph doesn't show the last 6 or 7 years, those percentages have just continued to increase.
According to the CDC, they define childhood obesity to be caused by any of the following: food, activity, sleep, social determinants of health, genetics, and illness and medications. When looking further into sleep as a cause of pediatric obesity, we know that insufficient sleep can cause weight gain, and of course, inadequate physical activity patterns can lead to excess weight gain as well. Social determinants of health can lead to pediatric obesity because, unfortunately, healthy food does cost more than junk food, and it can be fairly difficult for children to make healthy food choices if their parents do not have the funds to buy them. Also, these children may not have the opportunities for adequate physical activity based on where they live, learn, or play. These children and parents may not have good support, which can often lead to poor outcomes, including pediatric obesity. The CDC explained that there are variants in several genes that can lead to pediatric obesity by causing increased hunger and food intake. However, they noted that inherited obesity can be rare. Lastly, when looking further into illness and medications as a cause of pediatric obesity, it was noted that Cushing's disease could lead to obesity, while steroids or antidepressants can also lead to weight gain in children. So, what if a child is obese? What does this mean? Why do we care? Well, pediatric obesity can often have negative medical effects on these children. Some short-term effects that can result from pediatric obesity may include shortness of breath, increased cholesterol and blood pressure, joint pain due to the extra weight on the joints, and pediatric obesity can cause psychosocial effects on these children, such as low self-esteem, depression, or even anxiety. There are also long-term effects that can result from pediatric obesity. Some of these may include a risk for the child to develop obesity in adulthood, metabolic effects, cardiovascular effects, severe obstructive sleep apnea, type 2 diabetes, pseudotumor cerebri, hepatic steatosis, low self-esteem, and unfortunately, mortality.
Okay, so at this point in the presentation, we will move into the 4 ethical principles: autonomy, non-malfeasance, beneficence, and justice. So for autonomy, this is where we're really going to look at making sure the patient has the freedom to make their own choices regarding healthcare. With childhood obesity, with it being a pediatric concern, we want to make sure the family is also involved. So specifically, we'll be looking at family autonomy, and that will be further discussed in future slides. Then non-malfeasance, this is where we work to actively avoid harm, and we do this through conscious effort. Beneficence, it kind of goes along the same lines as non-malfeasance, but this is to do good. So specifically with healthcare professionals, we're working to do good for the patients. And then there's justice, and this is where healthcare professionals are working to make sure there's fairness for the patient and then also the family. So now we have the ethical dilemma case study that we'll go into. For us, we have Samantha, and she is a 4-year-old who weighs 120 pounds. For the past 2 years, healthcare providers have been working diligently with her parents to improve her diet and increase activity levels. However, she continues to gain weight and her health is deteriorating. In the past year, she's been diagnosed with diabetes mellitus type 2, sleep apnea, and hyperlipidemia.
So should we label childhood obesity as medical neglect? Based on the previous short-term and long-term effects that were discussed, pediatric obesity can be a medical issue that needs attention. Unfortunately, this means sometimes considering it as medical neglect. The article written by Vernice in 2011 defined pediatric obesity as medical neglect only when the following 3 conditions existed. Number 1, the child has a high likelihood of serious imminent harm. This condition aligns with the principle non-malfeasance, which is to do no harm. Number 2, there must be reasonable likelihood that the state can intervene and provide the child with effective treatment. This condition aligns with the principle of beneficence, to do good. Number 3, there must be no other alternative treatment options left for the child. While discussing the topic of pediatric obesity as medical neglect, it was made aware that this is not for the purpose of punishing parents, but primarily to protect these children from harm. When discussing autonomy, of course, the state wants parents to have autonomy over their children, and there is a high threshold for family autonomy. However, when the state identifies a major health risk for a child, that autonomy begins to diminish. This is when the state considers a child in imminent harm and must take over care. In the article by Vernice, written in 2011, pediatric obesity was broken up into 4 different categories when considering it as medical neglect. The 4th category was defined as a child having comorbidities that puts them in imminent harm. An example of this would be a child who is obese and then begins to develop obstructive sleep apnea and cardiorespiratory compromise. When looking back at our ethical dilemma of Samantha, the 4-year-old who weighs 120 pounds and has developed type 2 diabetes, sleep apnea, and hyperlipidemia, Samantha now has other conditions that put her in imminent harm.
While there are some strong arguments for childhood obesity being considered medical neglect, there are also some excellent points that suggest that childhood obesity is not medical neglect. As we mentioned earlier, there are varying levels in the severity of childhood obesity. And level 1 constitutes obesity without the presence of comorbidities that put them in any kind of immediate danger. Would it be justified to take away children from their families if they're obese, but they don't have any other significant health concerns? This also goes along with the principle of autonomy. As long as it can be argued that children are in a relatively safe situation, their parents have the right to make decisions for them. Although in our case study, we see that Samantha has in fact developed some serious health conditions, which complicates the situation. At what point do we remove the parents' autonomy? Where do we draw that line? We can also argue that it's unjust to take away children from families who are faced with disparities that put them at risk for obesity. We don't know Samantha's background, but would it be fair to punish her family for potentially being impoverished and not having access to certain foods? One could argue that this does not uphold the principle of justice. And finally, it should be questioned whether taking away a child from their family will actually result in a healthier life. The emotional toll would be huge. And can we say with certainty that they'll in fact lose weight in their new living situation? In Samantha's story, we see that the parents have in fact been working closely with the healthcare team to improve Samantha's condition. What if she continues to gain weight in foster care and now has psychological stress that may add to her health problems? Looking at the concept of beneficence, it may be better overall for a child to remain with their family.
And to conclude, we're going to end with our personal statements that we have regarding childhood obesity. We believe it's important to make sure that we're providing education to the family and help them find resources to better support the child's health needs. It may seem initially like childhood obesity is straightforward and could be an easy fix. Sometimes the initial instinct may be to judge that the parent is neglecting their child, but we also need to consider what resources are available to the family. Do they live in a food desert? What is their understanding of a healthy meal and portion size? Are they familiar with recommended amounts of daily exercise? As nurses, we can ask them what they feel would help them better support their child's health. At the beginning of this project, I think it's a tendency to think like, okay, mom and dad, be more present, just have the child get more active in sports, get them fresh fruits and veggies, monitor the portion control. But as we continued to work on this project, more light was shed, and you can really see how this is a complex issue where multiple things come into play. And then this could be where we mentioned earlier things such as poverty, language barriers, environmental threats, etc. So take, for example, our case study with the 4-year-old Samantha. We know that for 2 years, the healthcare team had been working with her parents to improve diet and activity. The parents were working with them to find a method that helps Samantha the best. At first glance, it might seem like she's being medically neglected, but in reality, the parents have been working with the healthcare team for a long period of time. So to conclude, we want to reinforce that the topic of childhood obesity is not black and white, and many factors play into the patient's obesity and overall health. And lastly, here is a compiled list of the references that we used throughout our project. Thank you for your attention.